I can remember back when a meeting like this would be held in a pretty small room and there'd only be about half the seats with anybody in it. So it's really gratifying to see this many people turn out to hear a talk, and I'm really happy to give mine. Once again, have given this kind of information a lot. Here's my disclosures. Thank you so much, Mike Report, and Ms. Timmerman in particular for getting me out here to Chicago to be able to do this. So I'm going to talk about this is a paired bilateral study. What this means is we had one patient had two different types of knee implants. That's what this is all about. And now we control all the variables. The only criticism I've ever received about why this might not be the most valid way was somebody said, well, people are like handed, only footed, that there's preferences, and there's no evidence of that somebody prefers one leg like they do our hand to another. So I don't think there's any real holes in the theory of it. And so I've kept with it all these years. So I did all the surgeries. They were all osteoarthritis, and everybody had kind of the same operation on each side. Sometimes they were some years apart, naturally. At the time of this data that I'm going to show today, I had 640 patients. We have more now, and this study's ongoing. I'm now comparing what we're doing to some robotically done cases is the leg I have now going. So I started in 1987. I'd been in practice a few years by then before I realized this is the way, because I heard a bunch of crazy stuff like, well, all knees are the same, or it doesn't really matter. And I heard that from, like John Insull. He just used his and it always worked. And we did exclude people that had poor outcomes on one side or the other because it wouldn't be a fair comparison then. So we ended up with 1,102 knees that we could really have good data on that follow-ups well past 9 years for the whole study. There are 5 types in the end that I'm going to tell you about today. The bicruciate knee, I'll show you a picture about that. That's not going to be so familiar to just everybody what that knee looks like. Then the standard PCL retaining, the post-stab, of course. And then we called this category when we started the medial lateral pivot because it wasn't really clear in 1998 when I started this, what path this was going to be. We now know it's the medial pivot, although we heard Dr. Banks talk about maybe dual pivot even. But at that time, it looked like it could be maybe the lateral pivot would be the way, and some of those were done too. But medial turned out to be the best way. And then mobile bearing, got interested in that, of course, from my good friend and patient, Fred Beagle out of New Jersey. Just saw him a couple weeks ago. Was IRB approved? And we randomized it. Did get everything just right? The patients their own internal controls, so every variable's held constant. There were none, as far as I know, a variable to be different. Really, that first question is the only question that we focused on. Which is your better knee? Do you really have a preference between your knees? And some people, not everybody does. I'll show you that some people say, well, they're both the same. But that's what we're trying to ask. We did also ask what rehabilitated more easily. I know today that gets a lot of information. I'm not sure that getting well quick and easy means you have a great long-term outcome, though. Having been in practice a really long time, I don't weight that as much as I might have early on. Because what really matters is this is a knee for your lifetime or not. I did watch patients walk on stairs, get out of chairs, ask them how they did those things too, as questions to answer. And we did find definite answers to that first question. Now, getting to the reasons the patients gave, that's a lot more complicated. A good many of them, they just don't know. They cannot, in a good way, verbalize this to you. Why is that one knee better than the other? Here's things they'll say, though. Feels more normal. Maybe it's better in single leg weight bearing, feels more stable, stronger on stairs. You did that one first. They might just randomly say anything. So I don't know the answer to that as far as a good reason for it. Some people, they don't prefer a total knee. If you get a patient like this, move on. You can do a great job on both knees. You're going to have them come by, which one do you prefer? Neither. And this will be your answer. There's the picture as promised of the bicruciate knee. And this was used by Dr. Townley as a big promoter of this. I did some of my early work with him, really looked up to him, still do. So this is a knee. It's kind of like doing two unicompartmentals. You don't dislocate the knee. You fit in a horseshoe-shaped tibia around the intact tibial eminence and both cruciate ligaments. This knee can always work out pretty well because in the end, if you put it in and you examine your patient very carefully, full range of motion, stress it when you're done, it won't work unless it's in pretty good. So the bicruciate knee leaves the OR with a knee that's pretty darn good. So then the medial pivot, of course. And here's how it came out. Look at these knees. 70%, if you compare the medial pivot to a posterior stabilized knee, that was considered the gold standard when I started. I don't think it is today. It wasn't then either, truth be told. 70% of your patients, they're going to tell you that the medial pivot's the better way to go. 10% don't know. 20% though will pick the posterior stabilized knee. Our medial pivots, they tend to be pretty darn good. 90% good pain relief, 92% could do activities, 60% rotational, 68% recommending surgery. That may sound a little low. It's actually pretty good. You know, Harley-Davidson owners, which are the most dedicated to their product, about 80% tell people to buy another Harley-Davidson motorcycle. So that number is not too bad. An iPhone is similar to that, for instance. Medial pivot versus posterior cruciate retaining knee. 81% will say the medial pivot was the better of the two knees, and only 12% will pick the one with the posterior cruciate ligament. Bicruciate knee, now there was no preference here. These were equally accepted side to side. And that sort of stands to reason when you think of, you know, all the bicruciates, if they got out of the OR, were well done, eliminated a lot there. Mobile bearing. I thought this would probably come out better because you hear people talk about how mobile bearing, you know, it's kind of mistake proof because you don't have to get it in great rotationally, it might still work. Patients, maybe the surgeon thinks that, but the patients didn't. It doesn't come out well compared to a medial pivot. I'm now looking at manual versus Mako. There's a failed Mako and its revision. I don't have data yet. I want many years of follow-up before I can tell you whether instrumentation will make the difference. It's hard to imagine that it would, that you can overcome design with good instruments. I don't think you're going to be able to, but people now are saying stuff like that. If you can just get it in good, it'll work good. Doubtful. So I want to encourage everybody to go to this as the way to look at your knees, because you're not going to be able to do bilateral comparisons like I did on all your patients, even I can't. But try to really get at the answer. Patient acceptable symptomatic state, pass. Do the patients really have what they want there? And you can do it for activities of daily living or sport. You really want a good number on that. These scores we've been using, knee scores, KOOS, even if you put things like minimal clinical important difference to make sure that the change in score is meaningful. This is not what people are, they don't care what their knee score is. They care if their knee is what they want it to be. And we really need to fully get where the patient is on this. Because I had paired similar knees, I could do other things, and we did. My patients would tell me that their knee felt warm. So we decided, well, we can tell you that, side to side, different knee in different sides. There are measurable differences. This would be like an objective way. There's no meaning to having a warm knee that I know of clinically, but there are differences. Bicruciate knee runs a little cool. Hinge naturally runs pretty darn hot. Medial pivot ran pretty hot, but it's pretty well preferred. I don't know the meaning of it. It just, once again, an objective way to say, are all knees similar? Well, they're not. Even in the same patient, they're just not. Noise. I put a whole paper on this about noise. Probably meaningless. Sound engineer told me that. But patients do bring it up to me. If it's important to them, maybe it should be important to me. Noise described as different things, grating, crunching, grinding. Is it a concern? Well, if it is to them, it should be to me. So I have a bunch of characteristics we added up. How often, when do you have it? What part of the knee is involved? Does it go away in time? Does it get worse in time? Again, differences. By Pritchett, not much. Medial Pivot did great on this. Very little noise. You look at the other ones, that's a pretty high frequency to get a complaint from your patient. I'm looking at stress shielding now because I can over really long intervals. I've been practicing a long time, got a lot of long-term follow-up. I'm a little less inclined now towards central stems on my knees because of that. That's not where people transfer their load in their normal knee, if you think about it. Unicompartmentals do the best on protecting. This is, again, the tibia. If you want to have good bone, and now that we've gotten rid of loosening and wear, bone retention is going to be important as far as long-term retention of our implants. Yeah, I think there was one more slide. Oh, yeah? So, summary. Do all knees work well? Well, I think we heard from Dr. Manning that they don't all this morning, and I would agree, at least not all mine do. Use the bicruciate knee if you have the gift for it. It does take time. It's hard to do. If you can get it in, and that's only if there really are good cruciate ligaments, give it a thought. If you don't want to spend that extra time, it isn't there, quickly move on. Medial pivot's just as good as far as patient preference. It's easier to do. But you got to put it in well. And it looks to me like this noise thing does have some meaning, and the medial pivot knee does that. Pay attention to the rotation of your components is the only other long-term thing I'll tell you from having been at this a long time. Thanks a lot for listening to my talk.